Okay, hi guys. I am going to do a screen share and we're going to go here. All right, this is going to be a quick lecture that I want to cover 4 injections. And I want you to have, instead of just posting the slides, this way you can have the video, you can come back, you can pause, you can write down any notes that you would like to take and review it again, okay? But our objectives for as far as injections is always going to be making sure, we have the right patient, the right med, the right dose, the right route. And those are called our rights. And I'm going to talk about that separately. All right. So we're going to assume as we're speaking now that we have all of that done. So we're going to get our materials together. And depending on the type of injection we give, we're going to pick out the type of size of the needle and possibly the syringe that we're going to need. And sometimes we're going to need to make sure that we have a filtered needle. And other times we're going to need to make sure that we have extra supplies on hand in case we come across any unexpected situations that happen. Because with injections and with blood draw or anything like that, you never know. Now, injections are pretty, simple. It's clear cut. You draw up the medication, you find the correct area once you clean the site and so forth. Right? That right? It's not the same. But I always like to have all of my supplies laid out. I like to make sure that I do not have to leave my patient or the procedure that I've started for any reason. Okay? Because this makes sure that I don't make mistakes and my area stays clean and I don't have any chances of patient interference. Okay, so this is just going over the steps. And this picture and what this is talking about here is how we have so many advanced needle systems. Okay, our sharps nowadays have many of them have built-in devices to prevent you from accidentally getting stuck, to keep you from having needle stick injuries, because we never want that. And that's why one of our very first rules that if we were in lab, I would be teaching you is we never recap, but if we do have to, we always take whatever hand. I'm a righty, so I take my left hand and literally, I'm in lab, I'll make you place it behind your back and then use one hand and basically just the one hand to put that cap back on the needle. And once it's up and secure, then you can click it into place and switch out the needle if need be. I would like you to always be in that habit. I never, never, never want to see you two-handed recap, even if the needle's clean. The reason is it puts you in a bad mindset. It allows you to think, okay, well, I did it this time, I'll do it that time. So we get in the habit. So, and I want you to get in the same habit, okay? And even though we do have these safety devices built in and that kind of stuff, just always keep in mind and always assume that the needle you're dealing with is dirty, is infected with whatever, okay? But the same thing with scalpels or anything like that. Anything you're dealing with is has pathogen in it or on it, okay? Always assume that. These are showing the different methods, how they click, slide, and then sometimes the entire tube will slide up to protect and cover the needle. We don't really, this is more for IV and IV medication pushes, so I'm going to skip that part. This part here is explaining um, a lot of times they're color coded. And fortunately, as an MA, we have the time usually to check and to take that few seconds to do that. But in an emergency situation, especially when I was a paramedic, every color was vital. I honestly had a lot of my drugs memorized and my packages memorized by color. And even though I was still checking them, that color helped me for, like lidocaine was pink, for a split second, make it a second faster that I could administer that lidocaine to that patient. Well, needles were the same way. And you can see here that they've pretty much stayed the same, but new packaging versus old packaging, but you might run across. But y'all really don't have to memorize this or get into the habit of this, because most of the needles that you're going to be working with, most doctors' offices, you're going to be seeing anywhere from 26 to maybe maybe an 18 gauge, but probably 21 to 26. And this is the range that you'll work with. This is just talking about, again, the different types. There's an eclipse kind in the safety slide. This is talking about the needles themselves and their links that they're available in, and what they're safe to use for and what they're not safe to use for. Okay, and if you this is talking about IV. This is, like I said, more advanced, but I'm bringing this up because I want you to see this. There will be times that we will draw medication with a filtered needle, okay? We need a filtered needle if we're drawing out of an ampule. And the reason is because when we ampules are certain medications that can't be kept in regular containers because of they'll either decay, lose their consistency, or their effectiveness and so forth. So they're kept in small, usually dark glass little bottles that have like a neck. And I'll be posting videos and talking about the step-by-step with this as far as how you break them properly. But at any time you use a medication from an ampule, you will always first draw the medication up with a filtered needle. And we do that to make sure no microscopic pieces of glass have entered in to the syringe. And then we would put our left hand or whatever hand behind our back, cap it back up, exchange that needle, and place a non-filtered needle. All right, so that would be, that's a perfect example of why we do need to know a one-handed capping system. But remember, I want you to think about, even if you know it's clean, always assume that it could be dirty. It could be infected, okay? Oops, went too far. All right, so, and this is an example of an ampule, and you see here this blue line and how that's the score part, and that's where you would take a piece of 2x2 gauze or something like that and cover with a gloved hand. You cover the area with the gauze, and then you just snap the scored, it's called the neck area, and throw that away. That goes into sharps because it is glass. And then with your filtered needle, you would pull up through there. And then this is a regular vial. And this is just bacteriostatic water. That's what you use when we're practicing and giving injections with each other. And this is just showing you the different types that they have, so you are familiar. Some of the needles in the lab that you might run across are already pre-attached. This means that the needle itself is attached to the syringe. Others, you're going to find that you will have to attach your needle to your syringe, okay? And then this is talking about if you're needing to give what's called an IV flush or a uh, uh, administer medication into an IV bag system. And this is called a lure. And could you possibly be taught that by a doctor? Possibly, but it's not something that we are trained as MAs. Okay. This is more explaining as far as more the IV systems. Okay. There are different types of the cannulas and needleless systems, but usually when we see these, this is going to be in an area where you have extremely infectious agents and patients like you're working with that they are just super precautious. I saw this a lot with infectious disease or on uh, units where there were a lot of patients who had possibly infectious uh, pathogens that were easily spread, bloodborne, that kind of thing, just to help prevent the patient, sorry, the nurse or the MA, whoever, from being stuck. This is talking more about the sliding and the mechanisms. You can go back and read and how that works and how the proper way to hold it. And then this is the lure lock connection. It's talking about if you have to connect it to a syringe, but you wouldn't really have to worry about that, okay? And now the safety locking syringes. These are new. We didn't have these back in my paramedic days. They have a very sharp needle. They have extremely easy readable marking lines. They have a very clear covering around the barrel. And then the flanges are large. And the reason that they're prepared like this and that they have these extra features to make them bold and to stand out is because they have this protecting over them. And after you've administered the medication, this simply slides up and protects your needle. So it's a very easy to and you can see a visual lock. It tells you it's locked. Incomplete, complete. So it lets you see so you know, hey, I'm safe. And some of them don't have the visual. Some of them have like a clicking sound, an audible sound. Now there's many different kinds of syringes. All right. And I need one of the things is to make sure that you are familiar with your syringes. And I'm going to be posting a printable worksheet to teams. And I would like y'all to, if you can, print it or write it out, but make sure you review this. Your syringes, it's vital that when you pick up a syringe, that you know exactly what syringe you're picking up. Because if you was to be told, I need that patient in room 2 to be given a dose of insulin, and you picked up a normal syringe and gave them, 3 mLs instead of 3 units, you could kill them. And so knowing your syringe, knowing its units that it's measured in, right, is vital for saving a patient's life. Most of your syringes are going to be ml. And here's the secret in case you didn't know. Write this down. ml equals cc. They're the exact same thing. So you might hear some docs say, I need mLs or cc's. They're interchangeable. They are the same thing. They're just different forms of the same unit of measurement. Okay? So ml and cc are the same. Okay? This is why we're covering this in lecture, the anatomy. We need to know the anatomy of the site we're going to give the injection. We never want to hit a major vessel. We never want to hit a nerve, like I was talking about the sciatic nerve. And landmarking is the best way to do this. And I was talking about the deltoid and how to use the palm and then the V shape of the arch of the hand here. And those are excellent ways. I always, even though I've been giving injections and stuff like that, I still always landmark my injections when I was giving injections, because everybody's body is slightly different. I may think that's the right area, but let's just, instead of thinking, let's know. And let's do that by making sure that we use a landmark and we do the proper area. Okay? You also need to make sure that you think about your patient's weight and their size, because thin elderly people are not going to need the same gauge of needle that, a 250 pound, 6'4" guy is going to need, right? So we want to see our patient and get a guesstimate. Okay, Mrs. Jones is maybe 107 pounds soaking wet. I am not coming at her with, a 1.5 inch needle, for her IM. She's a small, frail lady. So knowing your patient and knowing the proper size needle and stuff like that is important. And I actually have little cheat sheets that I'm going to be posting for you. And then also, there are appropriate volumes that you can administer into certain areas. Okay. And of course, I have sheets that I'm going to give you as well for that, because you don't want to saturate. Some injections have to be broke up and given in 2 separate areas, because placing the entire dose is too much on that area. It's going to be, and it's probably most likely going to be painful. It's going to be harder for the tissue to absorb and so forth. So, and I'll give you the details with that paper. The injection routes. Now, I know I was speaking about this earlier. Intermuscular injections, we call them IM. Subcutaneous, we call them either SC or SQ or sub-Q. I've seen them all different ways. And then there's the intradermal, and that's ID. All right. And I was explaining in lecture how your intermuscular injection is going to be the fastest way that we're going to, with injection form, that we can do to get a patient medication. Now, saying that, what is the most fastest way we could give a medication? Well, that's going to be IV, intravenous. Now, I do have MA students who have been trained to start IVs, and the doctors have trained them to administer medication via IV. But that's not something that an MA does with our training. And now, like I said, because you can always, when you go someplace, you may be taught a lot more than we ever teach you. And you're working under that doctor's umbrella. So you're working because they trust you, you feel secure, you feel safe doing it, and they've basically entrusted you with a new skill. All right. And that's common. That is a common thing. But the most fastest would, of course, be IV. But what we can do as a regular MA is going to be IM, and it goes directly into the muscle. And we know that the muscle is vascular, meaning lots of blood supply. Okay? This here is talking to you, and it's giving you volumes, right? And it's telling you about how much can be injected. If you read here, it's also giving you more examples of what's given IM and so forth like that. So take a few minutes, look through these, and talking about, like I was telling you earlier, the most common area is going to be the deltoid, and then the um, the upper gluteus, and these different muscles in these different areas are going to be the common injection sites. And I have a picture that I'm going to post. There are some rather uncommon areas that they can be administered as well, and I'll explain the reasons why we might use those areas. Now, subcutaneous, all right, this is, and real quick before I start subcu, let me just remind you again, when we do an IM, the needle goes straight in, and we always want a 90-degree. Okay? And then, well, now let's go to subcu. It's talking about how much. When you give something subcu, it should never be over 1 ml. Okay? Because you're saturating that area if you are giving more than that. Sub-Q injections are typically used for blood thinners, for insulin, for my daughter's like her migraine medication. It's something we give sub-Q when we want to get it into the body, and maybe orally is not the best route. So we place it into the subcutaneous or the fatty tissue, and it slowly absorbs from there into the muscle, into the bloodstream. And so it's a slower method, and it's a lot less painful to, especially to some patients who are really scared or sensitive of needles. Subcutaneous injections, you can pinch the area to pull it up, and I'm going to give you a printout that explains this, and I have videos for each one of these injections as well. And then intradermal, ID. The intradermal is for injections that are 0.1 ml or less. So just tiny doses. And we do this for TB testing. And because I said we're going right underneath the surface, usually whatever you inject is going to leave a bubble, or it's going to leave some kind of visible sign that you put something under there, because it's so superficial towards the skin that medication is able to be visible. And that's how like with TB testing, you want that visible bubble. Intradermal is also used sometimes for anesthetics, and it's sometimes used for allergens and stuff like allergy testing. But the main thing with remembering it is you would never put more than 0.1 ml, okay? And this is talking of the different injection sites. This is showing you for intramuscular, and this is the upper thigh. This area right here is the perfect injection site for babies. And pediatric will go through all on its own. But our pediatric patients, they don't have the muscles in their arms or, other places. So the place that they have a large amount of muscle and a large amount of fat is the thigh. So our injections for our peds are usually right in this area, and we'll talk about that. It's the lateral, I can't ever pronounce this, the vatus lataris muscle. And it's the, on the babies, it's where you got that nice chunky part. And then another common site for adults and older children is going to be the deltoid. And then we also can use the ventral gluteal site, all right? And then sometimes they'll use the dorsal gluteal site. And that's, you can see this area right up in here. And that's the one I was talking about in lecture, how you find the hip and place the hand and then with the marking location. Now, subcutaneous can be given in the, because it's at a 40-degree angle, right? I'm sorry, 45-degree angle. And what you want is you're wanting to get into that subcutaneous fatty layer. So you squeeze and pinch up the area at a 45-degree angle. You could use the outer aspects of the arm. I see a lot of people go in towards the back of the arm, the sides of the leg, even possibly back here. But the most common site is the abdomen, I would say by far. Or the what I see most diabetics go, they rotate this area and stick different places through here, and then the different parts of the arm. Now, intradermal, because we do, TB is always going to be right here, unless a patient's missing a limb or a limbs, or they're burned or they're injured, or then there are other options that you can do TB testing. Now, as far as allergy testing, we usually do them here, here, and sometimes they'll do them on the tops of the thighs. And it's going to be depending on the doctor and their preferences, or the patient and their preferences. All right. Now I'm already at 28 minutes, so I'm going to stop here and I'll continue the rest of this lecture. And I'm going to post this so that y'all can watch it, but I'm also going to post the sheets and the printable documents that I was talking about as well. Thank you guys. Have a nice day.